Okay, so welcome. And so maybe we just start with a short introduction of you. So maybe in 1 or 2 sentences, who are you? Where do you work? And in 1 sentence, what action would you take to improve antibiotic prescription in long-term care facilities? Who wants to start?
Tosca Bizzozzero. I am a GP and geriatric, and I work just in a long-term care facility. And I think to improve the use of antibiotic in nursing home, we should make more formation as today, but with GP, because GP they don't have any much formation about infection disease, sometimes, but not regularly. So we have to make some bridge between the infection disease and general practice to improve and to sensibilize the GP to this problem.
Thank you, Tosca.
Hello, my name is Clara, and I am nurse in the Cantonal Office Médecin Cantonal in Vaud. So I work with Emmanuel, and I'm in contact with nurses in a long-term care facility or nursing home. So the huge challenge that I receive from nurses is the resource. There's not so much resource in long-term care facility to get some training, also to monitoring antibiotic use. And also in the French-speaking part of Switzerland, nurses are usually alone in a nursing home, and we have directly to decide and call the general practitioner for some advice. So, yeah.
Thank you, Clara.
I am Emmanuel Lampedakis, and I am working in the Cantonal Doctor's Office of Vaud. I'm an infectious disease specialist. And regarding the second question, I'm not sure I'm going to say something very wise, but
guidelines.
yeah, as we said before, maybe make these guidelines more accessible and train the doctors and explain their existence already. Could be helpful.
Yeah, my name is Domenica Fluri. I'm working as an IPC specialist in St. Gallen, and I would stress a little bit what was already said before. We're doing a lot of nice things in long-term care facilities, perfect project, spot as well. We have a network in long-term care facilities, and we do not work with GPs. We have a lot of data, we produce data, you do such nice data. I think we have to go on the basis and see what they think they would need, nurses and GPs.
Thank you. So my name is Céline Gardiol. I'm leading the section Infektionskontrolle, Contrôle de l'infection at FOPH. And I'm also an infectious disease physician. So what we do at FOPH is more working at the governance level. So not only at GP's level, but more at this political level to have all actors in board. This is quite important regarding long-term care facilities because it's a very, very difficult topic setting. We had some new opportunities after the pandemic because we had the possibility to discuss with some actors which were not playing the game with us before the pandemic. So we are surfing on this wave now, but there is still work to do at this level as well. But I agree that GPs are very important, and I hope they will play an important role in the future.
Thank you. And last but not least.
Hello, my name is Silvia Richner, and I am a GP. I'm also palliative care specialist. I'm working in a big group private practice in Zurich. And I am responsible for about 25 patients in a long-term care facility nearby, so only 10 minutes by bike or 5 minutes by bike. But I am staying in our private practice.
And so what action?
There are different things. So for my practice, I think to work together with the nurses is really primordially, and I think we have to teach them on the small level. The responsible physicians should be in better contact with the nurses because they are calling us. So we have to know them. That's one point, and I think that would help that they don't do tests that are unnecessary or don't give you your information you need. And I think also on the political level that the GPs who are responsible for these nursing homes, they know these guidelines. I didn't know them before. So there must be also some pressure from above. So it's from the bottom up and from top down.
Thank you. So we start with a question for Domenica. So Domenica, I think the results you show were quite striking with the huge difference between French-speaking and German-speaking. So how do you explain these differences? You also show there is less infection in the German side. So is it only because they have less infection, or is there something else?
It's always the same question. I can't really give you an answer. I mean, maybe Emmanuel can help me as well. I mean, the thing is not so easy. The French part have more guidelines, also for healthcare-associated infections or for IPC. They have more guidelines, even not a lot, for antimicrobials. I mean, you do such perfect work in the Canton of Vaud, and still they use more antibiotics. And there's a big point d'interrogation, why is it like this? And I can't explain it. Probably it's differences in how GPs are formed, how they are, from which part they come. There was once the question if we had a look and spot how old the GPs were from the institutions, what kind of, from where they come, from which country they come. We do not have this data. But I think then there's maybe some cultural difference, even if France does not have, in their long-term care facilities, they do not have more, they don't use it. But we know from Switzerland, from the GPs that all, like in Switzerland, all hospital and ambulatory care, they use more antibiotics than do the German ones. So I think it's a little bit culture, maybe also how do you deal with the risk, perception. I mean, when they call you and say, Madame X is not doing well, and then what do you do then? And the step to give antibiotics is so close, even if the criteria are not fulfilled, but you don't know if 2 days later she's not doing, or she's worse. And then you can do a lot of nice diagnostic, but your gut feeling maybe, or the gut feeling of the nurse, I know.
Yeah, when coming with the train, we're discussing with Tosca, and she was wondering, but is it safe? So do you have like a higher mortality in this German side?
Mm-hmm. I mean, once I had a question, maybe we just do not use enough antibiotics. Maybe we should use more. I mean,
yeah, that's not the take home of the,
no, but that's the question. Or do the right patient gets the antibiotics, or maybe we treat the ones they do not want any antibiotics, but we miss to treat the ones they would gain something with the antibiotics.
Yeah, so we'll need more studies and interventional studies. Yeah.
How do you explain Italian is in between? I have maybe an explication because we say always Italian and French part are the same. But I think the most GP in Italian part are trained in German part. There are some of them trained in Romandy, but the most are trained in Zurich or Bern, not in French part. So I'm asking, is it really a problem of training and education of GP in French part?
Open question, no?
It's becoming a white table. No, what we know is that most GPs in primary care in the French-speaking part were trained in France, and that's probably also one of the reasons. So we can do the best we want in Lausanne or Geneva University, but in fact, it's not those GPs that will actually end up working in the long-term care facilities. I mean, some do, but not all of them.
Thank you. So I think we move to the next topic. So it's for Tosca. So in fact, since several years, in the Canton of Vaud, there are like quality circles, so organized by pharmacists, with physicians working in long-term care facilities, and you get feedback on your prescription data. So do you think this has an impact on antibiotic appropriateness or on your prescription practices?
Yes, it's true. We have this quality circle, pharmacist and physician and nurse in every nursing home. It's obligatory and it's financed by the Canton Vaud, so it's a very good thing. And it was possible to sensibilize the doctor, the practitioner, how much he prescribed, but of every medicament, not just the antibiotic. So at the beginning of the year, we have a view of what did we prescribe the last year about pain medicament, about antibiotic, about every class of medicament. And we compare us to the other nursing home practitioner. So we realize how much do we prescribe, and it's a good possibility to change, to look what the other do, and if we do all right or not. But for specific antibiotic prescribing, maybe it's not so relevant, because we don't look so much about which molecule we use, we prescribe for what kind of for infection.
In fact, you don't have the reason for prescription.
Right.
Yeah.
So, but probably the trend that we are prescribing a little bit less antibiotic, as we see in your presentation, the circle of quality contribute to this diminution, I think. But we should change a little bit this circle and sensibilize more on the specific molecule, on specific antibiotic, and perfection the circle.
Mm-hmm.
Yes.
Thank you.
And I heard you don't, with the financial economy of the canton, this quality circle will not be more paid or financed.
No, I think for the nursing home they continue but for GPs it's over. You know?
Yes, because it proved that it was very useful to diminish the economic part.
Thank you. Now a question for Clarisse. So, in fact, can you just describe a bit the process of antibiotic prescription or clinical evaluation you do in the nursing home when you have like a resident? So this morning, so you have a resident, he's coughing, fever. So what will you do, in fact, next?
Well, that's a good question, but it depends from each nursing home. Some nursing homes have, we have like some guideline. If you have this kind of symptom, you call the doctor directly, and then he will say, okay, you do the test, and then you give first this kind of antibiotic, and we wait the result. But also it can happen also like in case of UT. If you're someone who have UT, you just give the 1 dose of monorail, by example. So it's
so the nurses, they can decide on prescription. Okay.
Directly, there is a guideline with the general practitioner from the nursing home. It depends. So sometimes you call the doctor and you ask, what can I do? And it depends also which kind of infection that the patient has. Sometimes there is some guideline also. This patient have like urinary tract infection, and you give directly 1 dose of monorail, and then after you call the doctor and you discuss. Yeah.
Thank you.
Thank you.
Can I just ask you something? I mean, we have seen 1/3 has a prophylaxis. This is this long-term prophylaxis, this 30%. Could we use there any kind of informatic flags, like popping up if the antibiotic is more than a week? Because these residents, they have the antibiotics for months and years. And
I think, at least in the French side, that every nursing home use a different system. So it's a bit difficult to standardize, but
most of them have, and I was very surprised when we've done spot. We thought they're all working on paper, but that's not the case at all. They're very well. They're very well on their informatic systems. They do not have the same, because we wanted first to make an interface that we could automatically take the data. There was no chance, but I think all this system, they might have kind of like we say in the hospital, when you have a urinary catheter after day 3, something pops up and says you hello, maybe you don't need it anymore. That could be the same for antibiotics or antimicrobial substances, like 7 days of whatever. Do you really want to continue? And then a doctor has to say yes or no.
Thank you, Dominica. So like Noemi said, it depends from each nursing home. Some nursing home, if you have like an old patient with urinary infection, sometimes you take a sample and you do the stick, you do the interpretation, you call the doctor, and then you decide. Sometimes I cannot speak for all the nursing home because I don't work with all the nursing. It depends which place, which guideline. So sometimes you do what you can do, because you have to say you are the only nurse with 40 residents. So yeah, it's a little bit difficult. You need to take the decision directly. Yeah, it's different with the hospital. In the hospital, yeah.
But this prophylaxis is not something you do act. It's something that remains.
Yes. I know what you mean, that you give it before, prophylactic, but
and you forget to put the end date, and then but that's a good question, to see.
I
if
think
we
there is
have
more
like alerts.
I think we need more training, in nursing home, and for this, yes.
Thank you. So Silvia, you have a okay.
So thank you, Clara. Just a question. Can you harmonize this on cantonal level, the decision making? Is this possible?
In the Canton of Vaud, no, I don't think it will be possible to harmonize this kind of decision. And also, we have to think also there is also the habits. Sometimes also it's the resident who ask why I don't get an antibiotic. So habits is all take more time to change also than it's not so easy to harmonize. Thank you.
Thank you. No, so Silvia, Clarisse is calling you. The resident has fever. He's coughing. What do you do?
If the call is coming into my practice, it's already good. My reality is rarely that the call is coming. There is an email that I see perhaps in the evening with a positive urinary stick. Only the stick, no clinic. So I need... If I know he has fever, and then I can ask what is the pressure, what is the frequency of respiration. Normally they don't give it directly to me. So for my decision making it's really difficult. I have the chance I get a CRP in some hours. That could help, but the best would be going there and seeing the patient, because he's confused, but he has a dementia. So is this really a delirium, or is it not? And what is the decision-making advance directive? So all this, it's not, almost always it's not simple. There are individuals, and so So when I get the call, I ask for more information, and I need more information, and then I see if I or one of my colleagues, we could go there and try to relax a little bit, and even if it's with fever, it could wait 1 or 2 days normally. So, and it depends also the epidemiologics. At 4 weeks ago, we had one case with COVID, we knew, so all the others who were coughing, the probability were really high that is also COVID. So there is also this epidemiologic information that we need. But in the reality, there are 20 different doctors giving advice in this nursing home. So also for the nurses, that is really, really difficult, because one with fever and coughing says antibiotic, the second says this, the third says this. So this disparity of habits is enormous. So learning all together, I think.
Thank you. So is it different in the French-speaking nursing homes?
There is a great heterogeneity of action in different nursing homes. It depends on the practitioner. But I think the new generation, it will be different, because sometimes the old prescriptor, they are in habitude, they always do the same, they use, and they don't change, they use, they don't look at the guidelines, they are on their, they don't change. So I think the new generation, with the new possibility to online with the IE, so it will change. I think they are more sensible to antibiotic prescription, and that's maybe what the trend show. We are gonna prescribe a little bit less, I think. It will come. But the heterogeneity now is the problem. I think in some nursing homes they prescribe a lot of antibiotic and prevention too, and some other nursing home, they are okay, they look at the guidelines and they do it well. So that's the problem.
So if you could choose, yeah.
May I just ask something for Silvia? So we asked the institutions what they need, and they said guidelines and training and fewer diagnostic. If we would ask you, what would you need? More money for going there, or more time to, like, money is time, or time is money?
It's time and money, and now I will get the money next year. We were in with the nursing home that I have some time paid, not adjusted to one patient, and so now I will do some with the nursing team training, but it's also time and money. And when you have your patient in your private practice every 15-20 minutes in between, you know this, it is not the reality. And then it's the quick fix is just to say, yeah, give a monorail. So then everybody is fine. The nurse is, oh, we're doing something. You think I have done something. The patient also gets something. So everybody, but that's not good treatment, good medicine. But the reality, so time and money also, yes.
No. So maybe next one for Emmanuel. So.
It's a question to Domenica. Did you look at the French part and the differences between the antibiotic consumption within or between the nursing homes? Did you have a look? Because you saw that you have you're separating French, Italian-speaking and German-speaking areas. But when you see that there's a huge amount of consumption in the French-speaking part, did you try to look whether it's the same for all of them, or did you try to find differences?
There were more institutions in the French part with this really big amount of antibiotics, but we had also bad guys in the German and in the Italian. But that was the big question, is how could we reach the institutions, we thought of giving them, they all got a feedback, they all got the final review, but we didn't say, you have a problem in your institution. Yeah, a lot. Yeah.
Thank you.
No, definitely. No, definitely. I mean, we had 1 or 2 institutions until 30%, as I said, and there were most of the ones with a high were in the French-speaking part, but we had a lot of good institutions in the French-speaking part. Good, I mean, with a low level of antimicrobial use.
Thank you. So next one for Emmanuel. So it seems that also standardizing practices could be a solution, so guidelines. So how do you suggest to implement them to make them reach end users?
I think that we need to have something very easy to use on a daily basis with apps, for example, smartphone apps. That was initially our wish, but there was a lack of internal resources to do that. So that what we did in the meantime was an adaptive website that can make the work of an app in while searching for more money, and then doing regular training and reaching the GPs of nursing homes, but this is also quite challenging because there's such a big number of GPs working in these facilities that we do not actually know them. But fortunately, in Canton Vaud, we have a group of GPs working in nursing homes, and we can now have a list of them and reach them if we want. So yes, dissemination is very, very important.
Yeah, Tosca, you are the head of this group, so yeah, this could be a solution to go through this group to implement the tool.
But as usual, we have a group, but the person who come, the GP who come, they are not 50% or less. So there are always some GP who are not interested, who are not sensibilized to the problem. But it could already be a good idea to make regularly formation for the GP, and we invite the infectiology to speak to the GP. I also have to relativize, we have a lot of further problem too in nursing homes. So the infection disease are just one part of all the problem we have, all the formation we have to do. But we can do better, and we will do better next year.
Yeah, and we have something very unique, I think, in the French part. We have these PCI nurses. Part of the work got really inserted in the nursing homes. So, yeah, what advantages do you see to this model? So, is it something that we should implement in Switzerland?
I can answer, and you can complete if you want. So, yeah, actually, we have specialized IPC nurses in around 80% of the institutions. Their training is paid by the canton, and the institutions need to contribute the 4 or 5 days that they need for the training, so missing from their activities and money for the exam. It's a small amount. And the advantage is that for us in the cantonal level, if we want to implement something, it's easier because we know that we have some contact points we can reach easily. So if we do a campaign on influenza vaccination, we know that it is this nurse that we need to contact to come and take the material of the campaign. So for the implementation also of guidelines, when we wanted to send the paper guides, we knew who to contact. So it's more on the IPC side. infection prevention and control, but it can be used also for antibiotic stewardship activities.
Clarisse, do you want to add something?
Yes. Also, this one of the other advantage is when we give training to the nurses or other staff in the nursing home. Usually, we had also the antimicrobial stewardship in the training, so they have also time to ask some question and also to show that we are here for them.
And maybe the red flag in the system, in the electronic system, might be a nurse saying it's the antibiotic is there for 10 days. Maybe we should do something. So yes, we can train them, and they can play a role in antimicrobial stewardship. Nurses.
So next question for Céline. So as we heard, the antimicrobial stewardship program are quite challenging to implement in nursing home, difficult to design, to really fit the needs of the nursing home. So in your opinion, what could be like a context-adapted solution to effectively optimize prescription in nursing homes?
So a lot was already said. It is a very difficult setting because it is very heterogenic, and that is probably for us the major challenge, because we cannot come with one solution fits all. What we tried to do in the last 2 years is to improve expertise within the within institutions that the link nurses. We think that that could play an important role, because as we heard, GPs play a major role, but they are not there. And they cannot have all the information they need. And in a way, if you have more expertise at this level, this expertise will also improve the expertise at the institution in its all. Because they can train other nurses. So it's like the domino effect. And for us, and after a lot of discussion with cantonal authorities, we think that it has to be improved within the institution, but also at the cantonal level. Because if at the cantonal level you have more expertise in IPC, but also in stewardship, then you can improve the communication, you can improve the tools, you can have more control, and so it's a bit this strategical approach. And another point is that we have to keep that topic at the level of the public health issues. Don't forget that there are a lot of other issues, it was said already. And we heard a lot, no, but there is no problem in Switzerland. There is no AMR problem in Switzerland. The situation is good compared to other countries. This comes always in the discussion, and we are a bit fighting against that and saying, yes, okay, the situation is good today, but it might go to the wrong direction. So it is very important to improve teaching of future GPs. So it's all those aspects that should not be forgotten, and it's not enough to work at that facility level. It needs a bit more.
Thank you. And maybe something which is easier to implement, it's prevention of infection. And I think there is like the NOSO strategy action plan for nursing homes that is quite new, and maybe you can say some words on it.
So I won't say that it's easy.
No? Okay.
It's really not easy, because there is no expertise in the facilities. Canton de Vaud is a bit an exception. But it's true that after the pandemic, we saw the opportunity to develop something in that domain. So we have now an action plan for healthcare facilities, so that we can improve prevention of those infections. But what we don't know yet is how cantonal authorities and facilities will implement the plan. And but what we see that there is a movement. We see that there is commitment. People see that there is that we can improve the situation. And what is very different today is that the Dachorganisationen, les organisations faîtières, are working with us. So Curaviva, Séné Suisse, Séné Suisse maybe a bit less, but Curaviva is really willing to support FOPH in those efforts, and this is completely new.
But concretely, how will it look like?
It's lobbying. You mean
the plan?
The plan. So we have a plan already, and we have fields or topics where we want to improve the situation. The main topic is the link nurse. Another topic is that we want to develop at national level more expertise. So we will have an expert group at national level for prevention of infectious disease in long-term care facilities, because we don't have that at all. We have Swiss NOSO. Swiss NOSO is doing a lot for hospital setting, but nothing for long-term care facilities. So we are developing, and we are really lucky. I look there because the expertise comes from there. We're very lucky because in the last 10 years, there were quite a few clinicians that had the willing to develop expertise in that topic. There are studies, there are new information about this very, very specific setting. So we will develop this expertise in the following years in Switzerland, and probably this will also have an effect on stewardship programs, because, we hope so, or diagnostic stewardship. And so it comes a bit together. And another point is that we want to develop minimal Anforderungen, standards, requirements, sorry, for long-term care facilities. So we have that for hospitals already. Cantonal authorities included those minimal requirements in their contract with the hospitals, but this is only for IPC. And we want to develop the same for long-term care facilities, and we don't know what will be included, but it can be that we include from the beginning those stewardship or diagnostic stewardship within those standards, and the long-term care facilities will have to implement something.
And there will be resources dedicated to that, I mean additional resources or...
Je vais répondre, c'est le nœud de la guerre. No, so additional resources, probably not, but it depends. We know that some cantonal authorities really are giving more resources, but not at GP's level, more at nurses' level.
Yeah, but I think, Silvia, you said if you had like a nurse you know, you trust, and so maybe like, yeah.
But it's a long way.
Thank you. So I don't know if there are questions in the audience.
Thank you very much. We are at the end of this morning, but as a financial and organizer, except resources, I heard the message. What do you expect, you in the audience, from ASAP and from Swiss College of Physicians or family doctors? Concretely, after all we heard this morning, do you have any expectation?
So maybe I can start because I have an expectation. No, it's an expectation not only for ASAP but also for FOPH. So I give myself a mandate. No, but I think that we really have to work at another level and be very much more at this political, strategical level, because we see that if we don't fight at that level, then it doesn't. Yeah, it doesn't. Something is missing. And we have to do that together because it has to be a bottom-up and top-down approach. We cannot have only a top-down approach because it doesn't work. We tried that with epidemic law revision to have a more top-down, so and tell the GPs you will have to do that, and it's a no-go. It's a real no-go. So as we can't have this top-down approach, then we have to see together, okay, how can we have this bottom-up approach? And I really hope that all healthcare organizations will follow us, because now we are in this position that we fight. We have a fight. No, it's maybe too strong, but we're not all playing the same game because we don't have all the same goals and the same mission.
I think we have all necessary actors in the room, so maybe it's a good start to make the link between the political aspect and also the end users and their needs, what they need and what they are willing also to do to optimize the situation.
And if I may, another aspect is is that they are uncoordinated. It's normal, right? It's always like that, but there are uncoordinated measures and at different levels. So at the research level and the implementation level. And we are giving different messages. Just one example, very small example, CRP. Is it 150, 60? We don't all use the same level of CRP. In your
nursing
project,
home, it's always 60.
It's always 60. Good to know. But then your GPs,
For GPs is 100.
Yeah, 50 or 100. This is exactly what I'm talking.
I think you have to be.
Yeah.
I think you have to be very careful about the context you're working in, and this kind of context is 75 plus, and we live in an entirely different context. And it can be in medicine that you treat an 89-year-old woman the same as a 29-year-old woman. So you should use the same cutoff. You should use your clinical judgment, and then you add on the CRP.
Yeah, I understand that.
Never black and white.
Yeah, so I understand that, but you just have to. Well, you know that better than me. But when you're the GP, at the end, you don't remember. You don't have time to look specifically. So we have to think. Okay, can we really implement all those tools so that they are very easy to use?
Yeah, now we are using this first line guidelines, so it's an app that we all will have on our phone with guidelines. So I'm sure it will be easy to implement within the first line guidelines the nursing home guidelines, and so we could have like acute respiratory infection, and then you choose your setting, and according to the setting, it's not the same because patients are different and availability of doctors are different.
So I react, sorry, but you don't use all first line. This is not true. It's not true that all GPs in Switzerland use the same source for guidelines.
No. And in fact, we just started with first line, so it's not implemented yet. But I think it's a way to go to have like one Swiss. That's the objective, but it's not the reality right now.
Yeah, I'm not sure it will be one day the reality. And this is
so.
one.
Allez, last.
I have a wish as well for us up. No, I think what we would need for developing something maybe on a national or a cantonal or a general level is that we could use the network from us up to transfuse information on spot on whatever we would need in future with antimicrobial diagnostic stewardship, IPC. I think it's a network that is very important. That we'd be happy to work together.
Thank you. So I think a big applause to all participants of the round table.